Item number 9 is the Beaufort Memorial Hospital presentation by Mr. Russell Baxley and Dr. Kurt Gambla. And I will turn it over to them.
Good evening, Council. Appreciate you having myself and our Chief Medical Officer, Kurt Gambla, who is, looks like he's on the phone. Phil Foote asked us to present. As you guys are aware, we present weekly to the different and various leaders throughout the community to keep them up to speed on all things that are going on COVID-19 at Beaufort Memorial. In the beginning, that was obviously focused on testing, hospital capacity, PPE, and most recently, we're looking to update you guys on the vaccine. And so I think Kurt is going to go first, and Kurt Gamble has been good enough to prepare kind of a vaccine update related to the efficacy of the vaccine, the safety of the vaccine, and then I would be happy to go into the rollout of the vaccine, as it has been a moving target and frustrating at best. And that frustrating is a very kind word, a kind way to put it. I'm happy to talk about the rollout, what we know moving forward, and what at least Beaufort Memorial is trying to do in the next couple of weeks to continue to roll out the vaccine as quickly as possible. So, Kurt, you want to quickly go into your presentation?
Yeah, well, can you all hear me?
Yes.
Can you all hear me?
Yes, we can.
Okay, great. Hey, thanks for having us. So as Russell mentioned, I'll just make some brief comments about kind of where we think the medical community, or most of us, are sitting in terms of the vaccine and what our posture is toward it, and then we'll let Russell talk about the, I think at this point, much more interesting logistic and operational adventure. But anyway, the reason we think this is so important, of course, is that the United States enjoys the dubious distinction of being the #1 country in terms of number of cases. U.S. is responsible for 1/4 of the cases of COVID in the world to date, and 1/5 of the deaths. So that's over 25 million cases with over 400,000 deaths. So the vaccine and all the things that we've talked about are just as important, if not more important, today than they were at the start of this thing. And when you look at the curve, too, we're just coming down from what was our highest spike, I would say, about a week ago. So certainly, while we're seeing a little bit of a downturn now, it's too early to call anything a trend. So we'll see how all that goes. But anyway, next slide, if we can get to that next slide. So the first thing is, what I think is important to understand, because we get this question a lot, is how do we trust a vaccine that went from concept to delivery in 9 months? This is an unprecedented short timeline compared to the normally years to even decades in the history of vaccines. But when you really look at it and you look at the steps, and we'll go through those briefly in a second, nothing was skipped. The reason that we got here so fast, I think, is that we leveraged really some technology that hadn't been used before but has been around and studied for a long time, and then just an unprecedented coalescence of time, talent, energy, and resources that has never been seen in the history of any kind of objective like developing a vaccine. So I think that the timeline got compressed, but I don't think anything important was left out. And that's why I think most of the medical community is actually pretty comfortable with this. So this is how vaccines get approved. There's a bunch of work that's done preclinical, and that could be decades to years before the phase 1 trials start. And so in the case, for instance, of the two front runners right now, the Pfizer and the Moderna, this mRNA technology, which everybody says is new and novel, that actually was being looked at and studied for a couple of decades already. It was just a technology, I think, that was in search of an application. So probably about 20 years of homework done before even the phase 1 trials. Phase 1 trials with vaccines and new medications always are there to answer the question, is it safe? Things do not progress past phase 1 trials if there's some significant concern about safety. Phase 2 is trying to figure out the right dose, playing around with those doses and trying to find out the dose that's going to work, that's also going to be safe and effective. Phase 3 is, does it actually work? And every vaccine, including the new ones that we have now, go through all of these steps before they are even eligible to be reviewed by the FDA. So the FDA really relies on two independent bodies to give them advice, and that's the VRBPAC that you see there and the ACIP. Both of these are independent bodies that are not paid by any drug companies or any outside entities. They're as apolitical as they can be, or that you want to believe they want to be. But in general, this process is not subject to being tainted by pressure from the drug companies, the government, or any outside body. And only after those two groups meet and agree that the vaccine or the proposed vaccine or drug, whatever it is, has met those thresholds and those benchmarks for safety and efficacy, then do they say, all right, this is what it needs to look like. This is what we are going to recommend to the FDA. So right now, these vaccines are under EUA or emergency use authorization, and the only difference really between EUA and full approval is tincture of time. So the EUA says, we think we have enough evidence to make the call. The only thing that we don't know, because we don't have time on our side, is what does this look like 5 years down the road, 10 years down the road? It's an educated guess, though, and they do look hard at the data and try to, from the tea leaves, say, we think that this is going to be long-term a safe drug as well as efficacious. So that's how the process works for every vaccine, including the ones we have here. The 9 months didn't involve skipping any of these steps. Again, they were all just done in a very compressed time frame with a lot of capital, a lot of research and development put behind it. The Operation Warp Speed, I think, took the how do we get the capital together to do this part out of the equation, and that helped compress the timeline quite a bit. Next slide, please. We can't get to the next slide. I'll just go ahead. So talk a little bit about Pfizer. I'm assuming you all can still hear me, right? Yes. There we go. Okay. So Pfizer, that's the one that we're most familiar with. That's the one that that we are administering through Beaufort Memorial Hospital, and of course was the first one out in a lot of use over the country. So this is the new mRNA technology, and all that means is that mRNA is a protein that the body has. Every cell in the body has and makes mRNA. What they've done in the lab is take a little bit of mRNA out and sort of reprogram that so that when you inject it into the muscle cell, it tells the muscle cell, make something that looks a little bit like that spike. We've all seen those microscopic pictures of the COVID virus. Make something that looks a little bit like that spike. Our muscle cells make it once it's injected into the arm. Those cells and that mRNA within hours to days is gone, so there isn't anything that hangs around. And then the body makes a few of these spikes. It's enough to get our immune system then to say, hey, that looks like something that doesn't belong here. Let's make a bunch of antibodies to it. And that's really how mRNA works. So there's no nanorobots in there. There's nothing that hangs around permanently or does any kind of damage. This is actually a natural protein that's found in our body that we've just tweaked a little bit. A lot of discussion has come up about, well, what else is in the vaccine? And you can download the list and look. But basically, this is Gatorade and sugar water and some pretty benign stuff that's in the vaccine. So there's no... nobody's going to get mercury poisoning or lead poisoning or any kind of poisoning based on some crazy preservatives or additives that's in this vaccine. It's actually a pretty simple concoction. So this is 2 doses, about 21 days apart. There's 4-day leeway on either side. We do not consider the vaccine to be, or an individual to be fully vaccinated until 7 days after their second dose. So very important to get both doses, and very important to remember there's about a 7-day window before we think that that booster dose has triggered enough of reaction that we now have a lot of circulating antibody and that we can resist infection. Very effective. When they were initially trying to set the bar for efficacy, the numbers were around, hey, if we get something that's 50 or 60%, we may need to run with that. So the 95% is really hitting it out of the park in terms of the efficacy. The big downside, of course, for this vaccine is storage is problematic. It's got to be stored at a very cold temperature, as you can see. If you take it out of that cold temperature, you got to use it in about 5 days once it's refrigerated, and once you thaw it in about 30 minutes. Yeah, you can see some of the cautions, but even pregnant and lactating women can and have received the vaccine. That's a discussion with the individual provider. So there are no absolute contraindications, meaning there is not a group of patients over the age of 16 where they say you absolutely cannot use it. Even the allergy question is sort of a soft question because the only people who absolutely cannot take it based on allergy are people that have had this first dose and have had anaphylaxis, which is not a rash. It's not even a little bit of hives. It's the throat closing up and the shock and all that. And I can tell you that there have been very, very few cases of that so far. So again, very safe, very efficacious. Side effects are mild. They're self-limiting, usually go away within a couple of days, and certainly are not a reason to not get a second dose. Next slide. So thanks. The other one that's in very common use right now that's out is Moderna. Moderna and Pfizer are very similar. You can see there's a few differences. Moderna, I think, is going to be rolled out mainly through a lot of the pharmacies. I know some of the long-term care facilities, our military friends have been using it. And Moderna has got the same technology as Pfizer. A little bit different dosing schedule, 28 days versus 21. And the lag time is a little bit longer, 14 instead of 7 days. But for all intents and purposes, just as efficacious, just as safe. One nice advantage that it has, you can pretty much store it at kind of normal freezer temperatures, more or less, for 6 months. So it does not have the ultra-cold storage requirement. Otherwise, it's really quite similar to Pfizer. Next slide, please. So what's coming down the line? A couple places to look, and as you guys know, there's tons of information and misinformation that's all out there. If you want to just see what is in development in terms of vaccines, what countries have approved what vaccines, what's in phase 1, 2, and 3, and who's using them, there is a really cool tool that the New York Times has. It's the coronavirus vaccine tracker. So if you have a weird fascination with what's the rest of the world doing, with the hundreds of vaccines that are out in various stages of development, you can look on that and see at any given point in time kind of a worldwide snapshot. In terms of actual factual information about the vaccines, CDC has a number of different little sub-websites on the CDC website. If you just Google CDC vaccines, there's a lot of different places you can go within the CDC, which is very reliable, and will give you accurate information about what's actually out there, what are we using now, and what does it look like in terms of where we're going with our vaccine strategy. DHEC, as you know, has some vaccine information. I think there's a lot of ebb and flow on that as the supply chain continues to be a work in progress, but that certainly statewide is another place to look. But what actually is coming down the pipeline in terms of what do we think the next couple of vaccines will be available in the United States? Next slide. So AstraZeneca Oxford is working on technology, and this is the quote-unquote older technology. So what adenovirus technology is take a cold virus, the cold virus, for instance, that causes the common cold in chimpanzees, not in humans, because we don't want to give humans a cold. They take that, they tweak that virus a little bit, weaken it so that it cannot reproduce and make human beings sick. And then they reprogram that a little bit so that it actually looks like it has some spikes on it that, again, sort of mimic what we see on the COVID virus. They inject that, the body makes antibodies. So it's a little bit different technology. This is really more of the older technology, the technology that they've used, sort of similar to flu and Ebola and some of the other older vaccines that we've had. Easy to store, refrigerator. It is 2 doses at about a 4 to 12 week interval. And the reason I purposely did not put a lot of details attached to this one like I did to the first 2 is some of those details will be changed and tweaked as it goes through the EUA process and the various recommending governmental processes. But that's what we're looking at right now. When do we think that'll be out? Right now, again, it's a little fluid, but the latest thing I've seen is they're hoping to have enough data to present this to the EUA advisory board sometime around April, May. Next slide. And finally, the fourth front runner is the J&J, and I really like the J&J. First of all, it's got the older technology. I think the old and new technologies are both effective and work well. But what's great about this one dose, and you can keep it in the refrigerator. So I think once this one comes out, and depending on what you read, this may be weeks to months before. So I think this one's a little ahead of a little ahead in the running. One should get to the FDA a little quicker. And if it makes it through, this will be much easier from a logistics standpoint. So two in the pipeline, 2 available. And what do we need to do right now? Well, I think we need to continue to focus on getting shots in arms like we've been doing. But we have to act like we never got shots in arms. And what I mean by that is the masking, the social distancing, all of the other things that we've been stressing in terms of safety. We need to continue to do those things. The reason we need to continue to do them is, remember, 95 is not 100%. So if you got the vaccine, you potentially could still get infected, be an asymptomatic carrier. And when they did these studies, they studied who gets sick. They didn't really study viral load or viral burden, meaning in theory, you could carry the vaccine and just never become sick from it, but still be contagious. So we still need to mask, we still need to socially distance, and we need to do some version of that probably until we get about 70% of the entire population either vaccinated or recovering. We prefer vaccination because we think that the antibody response is much more robust and lasts longer from vaccination than it does from the old way, which is getting infected. So I think that's all I have for you guys. Thanks for your time. I'll turn it over to Russell.
So quickly on the vaccine rollout, because it's been clunky and, again, confusing and frustrating to most, and I'll try and say at a high level kind of why it's been clunky and frustrating, and then hopefully what the state and our local legislators are trying to do to fix some of this. You know, I think first and foremost, as we're aware, and I'm sure you guys have heard, VAMS is not a very user-friendly system. It is cumbersome. It is not easy to navigate. And there's multiple emails and steps you have to go through to schedule that appointment. And so for especially our 70 and older, it has not been an easy process to sign into VAMS, navigate, and finally schedule that appointment. I think the other, what I would say, frustration both providers and patients have in terms of the rollout of the vaccines is the inconsistent distribution of the vaccines to the providers giving them themselves. You know, South Carolina, as if you hear what Governor McMaster says, we believe is getting close to, if not what the federal government should be allocating to us based on population, which is about 1.5% of the supply, I believe. What I would say is that equates to about 60,000 first doses per week. Half of those being, I think, Moderna, half of those being Pfizer. Moderna, as Kurt pointed out, going to skilled nursing facilities, pharmacies, rural health clinics, those that don't have deep freezer capacity, and the Pfizer mostly going to hospitals and health systems. I think that in the early goings, that was okay. I think we were all, especially as providers, trying to find our way how to navigate distribution of these vaccines. And then the 70 plus was called, and I think hospitals very quickly ramped up their request. Unfortunately, when they ramped up their request, there was no heads up to hospitals, providers after the orders or during the call of the 70 plus to say, even though we're calling this group, there's only still a limited amount of supply, and that distribution, how we will allocate that is not yet known, because we later found out that there, on a county by county basis, on a provider by provider basis, there's no algorithm that DHEC uses that scientifically says this much vaccine should go here or this much vaccine should go there. And so when I think the request went in and the request was fulfilled, vaccines, I think, were disproportionately given to different providers. And unfortunately, that caused a number of providers to cancel appointments, including Beaufort Memorial. Right, wrong, or indifferent, we believe and have been talking with the SCHA people, as well as some in the state, saying, hey, we have been ordering, about 975 to 1,500 first doses every order. We also need to start ordering second doses. If we order first doses, can we get them? We would like to start scheduling, about 600 first doses conservatively per week for the next 10 weeks in order to start getting people appointments in a spot in line. At first, that was okay, and no one had any concerns about it. And then subsequently, we went from getting 950 to 1,000 first doses to 450, and then no second doses in that order. At this point, moving forward, that's, I don't want to say water under the bridge, but we had, after that point, after getting the notice of 450, we actually ended up securing another 350, and then another 950 second doses, and then another 1,000 doses from MUSC, which has actually allowed us over the past week to put well over 2,000 first doses in arms, and in this last week, and about 300 second doses in arms this week through 2 mass vaccination events. One was done this Thursday, a quick pop-up event with about 2 days planning at Beaufort High School, the football stadium. Very much appreciate traffic management. Beaufort County's Sheriff Department helped control the perimeter with traffic coming in, as well as Ladies Island Fire, Beaufort Police, and Beaufort County EMS, who all played a part in really vaccinating 1,066 patients. And then we did another small pop-up event this Sunday at our BMAC facility and vaccinated right at 300 people. Because the goal is at this point in time, getting every first dose that you receive can get a shot at the arm. I think right now the complicating part of that is you order your doses. Let's say we'll order our doses today, Monday, and they have to be in by Tuesday. We don't get confirmation that we will get those doses until Friday afternoon, and then they ship, and they may be here either Monday or Tuesday. And then we are, as hospitals and health systems, supposed to get all those shots in arms within a 3 to 5 day window. But we can't schedule appointments because we're not entirely sure that the doses we ordered are actually going to arrive. And so we kind of take now this all-call approach to say, all right, once we get our doses on, our confirmation on Friday, we can start scheduling patients, but we really don't count doses in the door until we actually receive them on our loading dock. So, for example, we did get 975 first doses today and 450 second doses. So we did get our order that we ordered, and we will be working to put those 975 first doses into arms before the end of this week in order to zero out that inventory. We will also be getting 1,000 more doses from MUSC. If you look at their allocation, right now they've only administered 50%. So through our partnership with them, we've been able to secure more doses from them. We will do another pop-up event to vaccinate close to, I think, 1,500 people this time at our Okatee facility south of the Broad on Saturday. So, most of this has been, I think, planned within 1 or 2 days' notice. We wait to get our confirmation on Fridays and then try to get as many patients in on Monday. What I can tell you, I get a lot of questions about canceled appointments. We have caught up all of those canceled appointments from last week and actually are ahead of the game at this point. This week, we are honoring all of our VAMS appointments that were in this week. So we are back on schedule for what was for what was canceled, and so nothing has to be rescheduled going forward. And we are contacting each of those patients to say, please keep your appointment that you already scheduled in advance, because we are now able to honor those appointments because we are now in excess of inventory after about a week and a half and a lot of back and forth with the state and NUSC. And what I would also say is that we are have about a backlog of about 6,000 to 7,000 people who have contacted us requesting an appointment that we have not been able to schedule yet because of the inventory concerns and issues and the complexity of the process as it stands today. But we are working to, for example, that list of 6,000, put them in now a queue, and we're starting to call them back as well to schedule them appointments either at one of our 2 clinics and or at this mass vaccination event that will be popping up on Saturday, and that will be by appointment only. What I would also think, I'd lastly say in terms of what we're trying to do is that we have been in constant contact with Councilman Passament, as well as Tom Davis, Shannon Erickson, many of our legislators to help advocate for Beaufort County in terms of getting more doses, in terms of getting excess doses for stand-up pop-up events on some sort of schedule and cadence that we can partner with many in the community on. And hopefully, after, I think next week, we'll not only see an algorithm coming from DHEC as to, how doses are going to be distributed, but I think secondarily, hopefully request and DHEC honor, I think, the ability to get additional above and beyond for said pop-up events when scheduled. So I will pause there and open it up for Kurt and myself for any questions from the council.
Questions from council members. Mr. McKellen. Please unmute yourself.
Okay. Hey, Russell, I have a couple of questions on your pop-up. Are you limiting that to 1A? Category 1A?
Yep, right now we are. If we find that we don't have enough 1A, again, we have a long list. We will potentially open it up to, others because we want to get shots in arms. But right now we are still in 1A and trying to work down the backlog.
Okay. And how do you register for the pop-up?
Register for the pop-up right now. What I would say is the best way to do that is to contact us on our BMH website. We have if you go to our website, you go to the vaccine banner, and when you log on, when you get to that landing page, there is a 70 plus or 1A link. You need a vaccine. Click on that link, and there will be an active sign-up form that will put you in the queue to be called back.
So the pop-up is a 1A and 70 plus.
That's correct, and we were starting to work. We're working that list this week to start contacting people who are waiting for the vaccine.
Thank you.
Yes, sir.
Other questions? Mr. Cunningham.
Yeah, Russell, is it possible that the slideshow you gave us, can we send that out to our constituents on our own outlets?
I have no problem, Kurt.
Yeah, no, I'm fine with that.
Just to give them the information. I know some people, not everyone's going to watch, but just getting that, information on paper for them on another outlet other than just a specific website.
Yep, absolutely.
Thank you.
Any other question?
If I might, Mr.
Okay.
Chairman, just for Councilmember Cunningham, what we may be able to do is just have our broadcast services edit down that portion of the presentation where the doctor is talking, and we can email that to you all to put out on your outlets if you want to. That way people don't have to go through the whole meeting.
That'd be fantastic.
Excellent. And as Russell said, we are working feverishly with our legislators because DHEC on February 1st is going to roll out their methodology. We're going to be sending out a letter on behalf of the municipalities and the county to talk about them considering the factors that are pertinent to us because we have large elderly populations, rural communities, and minority populations that the data show that we need these people vaccinated as soon as possible. We're planning additional events. I want to tell you that the BMH event at Beaufort High School went smoothly. They vaccinated 1,066 people. If they had another 1,000 vaccines, they could have vaccinated another 1,000 people. The sheriff's department was there. They did the traffic coming in and the traffic leaving. The input was done extremely well. They had the lines set up. The personnel who were giving you the shots were careful, they were knowledgeable, they did everything they possibly could, and Russell was there himself, making sure that people were talked to, and it was a wonderful event.
Mr. Chairman.
Mr. Glover.
Yes, and I thank you, Mr. Chairman. I thank you, Mr. Baxley, for your effort that you're making. But just want to just say that a lot of the rural community really do not have access to a lot of the technology and the internet all the time to sit before a computer to get a schedule for an appointment. So just keep that in mind and try to work out something in reaching out, because that community actually, the death rate is much higher there than any place else. So just keep that in mind.
Well,
Appreciate all the effort that you're making. Thanks.
That is spot on. And what we're doing is there is an outreach program going out to help those people who don't have computers, who don't have cell phones, who don't have email address, to get them the information so that we can register them. We're working on going into the rural communities. We were on a phone call today whereby Yemassee has offered for northern Beaufort County the ability to use their facilities. So yes, we're well aware of what's going on. Mr. Flewellen.
Thank you, Mr. Baxley. How is the hospital compensated for all this valiant effort? I must say, I'm very grateful that you're doing this. How's the hospital compensated for that?
So we do collect insurance, or try to collect insurance information, and all we're allowed to bill for, because the vaccine is free to everybody, is just the administration of the vaccine. So there is a code. It should be covered at 100% by your insurer or by Medicare. If they have no insurance, we're writing it off to charity care. So we're just collecting what the insurances are paying, and if there is an out-of-pocket, we're writing that off to charity care as well. We're trying to collect what we can. What we can't, we just write off and move forward.
Thank you.
Sarah, did the feed just cut out? I just got a text message from someone who has been watching and said the feed cut out. Would you check that, please?
Yes,
Any other questions from council members? Well, Russell and Dr. Gambla, thank you very much for what you're doing. I know you're very busy and appreciate you taking the time to come and present to us.
Our pleasure.
Thank you. All right, item number 10 is our liaison and committee reports. At this time, I would like the Executive Committee Chair, the Finance Committee Chair, and the Public Facilities Chair to address the consent agenda items.
Hey, Joe.
And then we'll have any other reports from anyone else. So
Hey, Joe, this is Mark.
begin with the,
Joe, this is Mark. I was just informed that broadcast is down.
okay. All right, so then we're going to pause for a moment till they're up